We're so excited to have you here today. We have a really great list of speakers, a really packed agenda on our last module. I want to start by asking you to please mute yourselves if you are not speaking. We'll have an opportunity at the end of the session to ask questions, and you can also add in your questions in the chat box throughout. I am so excited to share with you the agenda for today. And first, I wanted to just start off with a little overview of our entire series. So I am Isabel Rovira. I'm with Urban Health Partnerships, and we are working with the South Florida Geriatric Workforce Enhancement Program to provide 4 learning opportunities for healthcare practitioners with an emphasis on nurses focused on this age-friendly health systems framework, which was developed by the Institute for Healthcare Improvement. Participants will learn what the forums mean, how to practice forums in the healthcare setting, and the importance of age-friendly health systems. So this is, again, the number 4 of 4. And we started off with an introduction. The last 2 sessions were focused on what matters most, mobility, mentation, and medication. And today we'll be putting it all together. And with that, I want to show you our agenda for today. It's very packed, full of great information to start you off on your age-friendly journey. And we are going to start off with Megan Wolfe from Tifa. We're going to go into considerations around implementation with Tanya Hoffman, putting it together with Denise Krasinski, and lastly, we'll have Dr. Pandya, who we heard from in the first session, wrap up for us and provide next steps. And at the very end, we'll do a Q&A. So now I want to introduce to you our first speaker, Megan Wolfe. She's a Senior Policy Development Manager at the Trust for America's Health, where she works with the policy development team to advance a modernized, accountable public health system. Her current work at Tifa focuses on advancing age-friendly public health systems in state and local public health departments. Megan has been engaged in public policy and advocacy for 20 years and has represented Fortune 500 and nonprofit organizations. Prior to joining Tifa, she served as a government relations manager for ASCD, an international education association comprising teachers, principals, superintendents, and higher education professionals. Megan received her undergraduate degree in government from the University of Texas at Austin and earned a JD from the Antonin Scalia Law School. Megan's going to be talking to us about the aging and equity data indicators that are available to us on Florida charts. And with that, I will hand it over to you, Megan. Welcome.
Great, thanks so much, Isabel. It's really great to be here with all of you to be able to share some of the information and to introduce you to the Aging in Florida profiles, hopefully provide enough information to get you started in your own explorations of data. I'm going to start with an introduction to Tifa, Trust for America's Health, provide some background on our age-friendly public health systems project and how the Aging in Florida profiles were developed. And then I'll do a quick demonstration. I'm not a public health or data, particularly a data expert, but I should be able to give you enough to get you started. Next slide, please. Trust for America's Health, or TIFA, is a Washington, D.C.-based public health policy, research, and advocacy nonprofit. We focus on improving the conditions for health so that every community and every person has the opportunity for optimal health and well-being. We publish a number of reports every year. We engage in robust federal advocacy and lead national convenings to develop policy recommendations on our priority issues. And these include emergency preparedness, public health funding and infrastructure, obesity and nutrition, substance use and suicide, and the health impacts of climate change. Healthy aging is probably one of the newer issues for TIFA, but despite how new it is for us, we've been really gratified with the response across the country from state and local health departments in embracing this work. Next slide, please. So as many of you know, public health is about what we as a society do collectively to assure the conditions in which all people can be healthy, including creating and supporting the policies, conditions, and environments for good health to prevent disease, illness, and injury. Now, before COVID, public health in general has not had a strong overall focus on older adults other than some very disease-specific interventions like the Healthy Brain Initiative and falls prevention. For most states and local health departments, there just has not been the capacity, nor really even the awareness of why public health departments could address older adult health and well-being, or why they could or why they should. And CDC just last year created a new healthy aging branch within the Division of Population Health. But many of the programs that focus on older adults are still siloed in other divisions in CDC. And even the president's budget that came out last month does not fund the healthy aging branch beyond the programs already existing that are disease specific. The Older Americans Act provides funding for programs that contribute to the health of older adults, but that funding goes to the aging network and not public health. With the prevalence of preventable chronic diseases among older adults, the value of public health engagement in older adult health becomes starkly apparent. And we've seen that particularly with COVID and the prevalence of disease and death among older adults. Next slide, please. So Tifa launched our Age-Friendly Public Health Systems Initiative in 2017 with a convening of public health, aging, healthcare, and academic representatives that resulted in the framework for creating age-friendly public health systems focused on 5 key categories or roles for public health, which we call the 5 C's framework. And you can see the categories on the slide. So while the Age-Friendly Health Systems framework has 4 M's, we have our 5 C's, and they are connecting and convening multiple sectors, coordinating existing programs to identify gaps and priorities, collecting data, communicating about best practices, and complementing existing supports and services. Next slide, please. So to test the framework, we conducted a pilot there in Florida, funded by the John A. Hartford Foundation. We worked directly with 37 of Florida's 67 county health departments that all committed to becoming age-friendly public health systems. They developed a vision for their jurisdictions as well as action plans focused on priority areas for older adult health unique to their own communities, and that the public health staff could get started on immediately. Most of the activities among these county health departments have not required additional staff or funding, but still reflect really meaningful changes toward creating an age-friendly public health system. We have now, this year, entered into phase 2 of the age-friendly public health systems work in Florida, and we will be adding 9 more county health departments to the Learning and Action Network, and we'll be deepening our work toward eliminating health disparities. Next slide, please. So what did we learn from the Florida pilot? First, we learned that public health needed data in order to identify the older adult population in each of their counties and determine where to start, where to prioritize their activities, and especially to reduce health disparities. So we convened the Department of Health data administrators and the Department of Elder Affairs data folks, because they have their own elder profiles, and the participating county health departments, and worked with them to identify the data they deemed most important to begin this work. So what you're seeing is a screenshot of the Aging in Florida profile for one of the 67 counties. And even today, these profiles are being analyzed and updated to be sure that the right data is included and that's easily navigable for health departments and others to identify priorities for action, enlist allies, and compel policy change. So Isabel, at this point, if you want to allow me to do a screen share, and I will try and bring up my screen. Sorry, I'm trying to find my my online, which I don't see. Here we go. All right, so this is the wrong screen. Sorry about that. Okay, here we go. Florida health charts. Can everyone see the Florida health charts on the screen here?
No, it's showing the team meeting chat.
Oh, it is. Oh, bummer. Okay. Let me stop and try again. Sorry about that. There we go. Okay, now can you see Florida health charts?
Yes.
Great, thank you. Okay, so here's where you want to start. You go to floridahealthcharts.com, and this is the main screen that you will bring up. And this is loaded with information. There's so much data here. There's actually 4,500 data points that are accessible through charts. You can see, all the different ways of looking at the information on the left over here, where you have the different navigation panes. And also, if you go to the top right here corner where there's the little what are you looking for box, we could just type in something like falls. And if you want to just look at the data that they have on falls, this is what you get. If you want to go further into this, you just click on some of the data that is available there. See how long this takes. If it takes too long, we will, oh, there it is. And each of these are county specific. So then you would want to go and pick your county. It should automatically adjust to that county and bring up the data. And what you see on the left here is a comparison of the data from Florida. And you can see that falls, hospitalizations for non-fatal unintentional falls have gone up in Florida. But in Miami-Dade, they've gone down. And so that's a good statistic. And then on the right, you'll see the data for every county. And you can compare it. Obviously, the darker the block, the county, the worse the statistic is for this piece of data. All right, so I'm going to go back and get you into the actual aging in Florida profiles. So to access the aging in Florida profiles, you want to go over here under county profiles and go to population specific, click on that, and you'll see aging in Florida right here. So we'll click on aging in Florida. And again, this information comes up. There are 4 categories of data: population, family and living arrangements, education and financial status, health status, and behaviors. You'll want to select the county first that you're interested in looking at. We'll stick with Miami-Dade. Click on display report, and all the data for Miami-Dade will populate here. So I want to show you, if you want to look at, for example, Black non-Hispanic, this is just the population data. You can click on that and more data comes out per age group. So you can actually do a count here, starting with age 65 and do 65, and count all of the group, and you'll get an actual number. And here you have the percentage rate. And each of these pieces of data compares the county to the state. So we'll go back. I think that probably the most relevant for this group will be the health status and behaviors. And I know not a whole lot of time here, but I just do want to give you a couple of ways of looking at some of this data. And a couple more pieces. So if we look at this, the first one, reported good, very good, or excellent health status. Again, you can click on the plus or minus sign and get the breakdown of race and ethnicity. And it compares the county numbers to the state numbers. And these are rates for good reporting of good, very good, or excellent health. And I just want to also show you the superscript numbers next to each of the pieces of data identifies the data source. So you can click on that and see that this particular piece of data, adults who said their overall health was good to excellent, comes from the CDC's Behavioral Risk Factor Surveillance System, or BRFIS, and that comes out about every 3 years. So it's not as up to date as some of the other data that Charts provides, because it is an every 3-year piece of data. Okay. So I want to, I can't go back because I can't see the navigation bar. Sorry, folks, I just need to minimize that for a second so I can. I am so sorry. This is not behaving the way I wanted it to.
Great information.
Yeah, so this is. Sorry, folks. Here we go. We'll go back to Florida. Here we go. Okay. So back to the aging in Florida profile. And I just did want to look at a couple more pieces of health status information. So you can just see there's a lot of information here. You have people with a disability, you have Medicare enrollment, which might be of interest to this group. And again, probable Alzheimer's cases, those who received a flu shot, hospitalizations due to mental disorders. So if we want to click on that one real quick, I'll just show you one more way of looking at some of this data. If you click on the actual description of what the data is, you will open up what they call the 4-panel viewer. And the 4-panel viewer gives you, again, a view of a comparison of the county data. And now we're looking at Alachua. So that is, Alachua is in the gray. You can see the kind of ups and downs in terms of hospitalizations. And then the Florida data is on the blue line. Again, you have the map, which you can scroll over and look at each of the counties and the rates of hospitalizations for mental disorders for each of the counties. If you scroll down, you can look at all of the data over the course of the years. So you can do a comparison there. And then the rates in each county compared to the state. So I think that my time is up, so I'm going to stop sharing here. I hope that that was enough of an introduction to at least give you a sense and make you hungry for looking into more data. The people at the chart system that administer it are very open to questions. There is a place where you can ask questions and put, get very specific information about what kind of reports you'd like to generate and so forth. So again, thank you so much for allowing me to share, Isabel and everyone. And I look forward to the rest of the presentations.
Thank you so much, Megan. And this is a great overview of a really amazing resource we have here in Florida that didn't exist a couple of years ago. And actually, I hadn't seen that in a couple of months. And there's even new data and new tabs on there that it looks like it's continued to be updated, which is really wonderful. And we can see how some of this data might also overlap with our age-friendly health system work. So with that in mind, I want to now go to our next speaker. Let me share my screen again. And I want to introduce to you Tanya Hoffman. She is a geriatric program coordinator at Sarasota Memorial Hospital and was the leader in the quest to develop their age-friendly program, achieving the Committed to Care Excellence recognition in August of 2019. She has a very diverse nursing background of 38 years, starting out as a diploma graduate in emergency nursing to working as a clinical nurse specialist in paranesthesia nursing. Her latest role has entailed the creation of an interdisciplinary team focusing on the needs of the geriatric population in Sarasota County. She continues to use the CNS spheres of influence, patient, nurse, and system to work both in the hospital as well as the community to improve the lives of older adults. And Tanya is going to be talking to us about things that we should be considering as we look to implement age-friendly health systems. Welcome, Tanya, and I'll pass it over to you.
Thank you so much. I am so excited to share our journey to age-friendly and some considerations that you should be aware of as you join your own team's journey to age-friendly. Next slide. So we're going to talk mainly about why become an age-friendly healthcare system and what that means for your organization. Next. So we all have heard, if you build it, they will come. And who wouldn't want to come, right? So what we're finding is that according to the U.S. Census Bureau, the U.S. population age 65 and older, we all know is expected to double over the next 30 years. And that means about 83.7 million older adults in 2050. These advances, however, we're not ready for that. So even though we're not there, they're coming anyhow. So what we're finding in Florida, and particularly in Sarasota, where I am, is that there are, according to the State's Office of Economic and Demographic Research, an estimated 330,000 new residents that came to Florida between April of last year and April of this year. Florida was the #1 destination for relocating Americans in 2020, and an average of 845 new residents a day are coming to Florida and are expected through 2025. We're seeing younger adults, or younger retirees. Next slide, please. But if that wasn't enough to make you want to join the age-friendly bandwagon, consider this. 13 of the top 25 places to retire in the whole country were in Florida. And my particular area of Sarasota was #1. And I'm not sure that that's necessarily where we want to be in that race to the top. But we now are seeing the fruits of positive aging. But now, how do we deal with this population that's exploding in our area? Next. So let's think a little bit about the age-friendly journey. And some things you want to consider is, how do you do it? Who are you focusing on, and where should you focus your attentions? Next. So first, you need to know your patients, and Megan kind of gave you an overview of some of the information that is being looked at by IHI when you start this age-friendly process. So you need to understand what percentage of your patient population is under 65. Is it even worth your while to really put a whole lot of resources and influencing the changing practice on that population if the majority of your population is under 65? How many are over 65? And our population here in Sarasota is a little bit interesting in that on any given day in our hospital, 67% of our patients are over 65 and 27% are over 80. So on any given day, I can see 25% of the population even over 90. So it's something that we focus on a whole lot. But this has shown us that our 4M model that age-friendly kind of looks at is important for our organization, and looking at those demographics, it may show that yours are too. You also need to know, though, what are the race and ethnicities, what are the cultural preferences of your community and the patients that you serve, and then most importantly, for those of us who are interested in keeping those readmissions and length of stay data down and manageable, what's the health literacy levels of your patients so that you know, again, where you want to focus your efforts. Next. So you need to know about your organization. So what processes do you already have in place, and where are you maybe able to practice those 4 M's already as a set? So we did a gap analysis that showed us that in our particular organization, mentation was where we were failing a little bit. And I think that the majority of organizations are just now coming on that bandwagon where we need to really be looking at the rate of delirium in our older patients and how can we prevent that and decrease those numbers. Looking at mentation also helps us understand what matters most to those patients. The medication, making sure that none of those medications that we're giving patients are going to impact their mentation or their mobility. And then eventually they're what matters most, and then mobility. So again, really examining what your organization is successful with and then where to focus your efforts. Next, please. This is probably the most important, looking at this from my background as a case manager, is knowing your community. Many of us think that discharge ends when the patient hits the door. And what I find is that a lot of our patients return to us because we didn't give them the resources or refer them to the agencies that maybe would help them be successful after they leave us. So we're a very lucky community in that we have ITN that helps with transportation. We have a robust Meals on Wheels program. I have a very strong relationship with the Alzheimer's Association. We have a memory disorder clinic here at the hospital. We have a robust senior friendship center, a Suncoast Center for Independent Living, and the Jewish Family Children Services Agency as well. Next slide, please. So some considerations for success: obtain a champion or maybe two. It is helpful to have someone in the boardroom that can help you with your endeavors. It's a little difficult to do this without having some physician buy-in. Creating a steering team. And we actually found that it was most helpful to not only have leadership and physicians, but also nurses, therapists, pharmacy, clinical systems to help us make our electronic medical record work for us. Some volunteers. We have utilized volunteers a lot as visitors, which has been helpful as we're coming back from the pandemic, educators, and then again, most importantly, an older adult from your community that can help give you a perspective from their side of the bed. You want to start small. What we found is we looked at all of our different nursing units and really paid attention to the ones that we were doing most everything correct and using the 4 M's. And then from there, we started building on that throughout the rest of the organization. Then identify the most important initiatives which align with your organization's strategic plan. So if you can show that what the organization is looking for, you can help them, it gives you a lot more buy-in from leadership and the organization as a whole. You need to
I'm not sure that
keep evolving and revise things that aren't working. So don't think that you're going to put together a perfect plan your first go round. If you do, wow, you're great. But just realize that this is as we do with the nursing process, it is an evolving and fluid process. More literature becomes available with our research in different things that apply to the 4 M's. And then most importantly, celebrate your successes and spread the care throughout the rest of your organization. Next, please. Are there any questions?
We're gonna hold the questions to the end just so we can get through all the presentations, but I definitely think we'll have a really great conversation at the end. Thank you so much, Tanya.
Thank you.
So inspiring to see everything that you've done in Sarasota. And like Megan mentioned in the chat, you're also leading the way in age-friendly public health. And all of this is really important and connected. And together we can build a community where older adults can stay healthy and have healthy aging throughout their life. So now I'm excited to introduce to you our next speaker, Denise Krasinski. She's a clinical trainer at Nova Southeastern University and working with the grant support of the HRSA grant to implement age-friendly healthcare in association with the Geriatric Workforce Enhancement Program of South Florida. She has worked with patients across the spectrum of age, culture, and illness acuity, first as a registered nurse, then as a nurse practitioner. As a nurse practitioner, she has worked with high acuity geriatric patients, homeless individuals at FQHC, and she has worked with indigenous tribes of North American Indians as a provider of at FQHC in Western Oregon. In addition to her work as a clinical trainer for age-friendly health, she also works as a provider to U.S. military veterans suffering from toxic exposures of war, neuroinflammatory and mitochondrial dysfunction, and those who have been afflicted with long-term sequelae of COVID-19. Her previous work as a nurse practitioner, she worked for 25 years as a trauma and critical care nurse at Memorial Regional Hospital with various roles at the bedside, in hospital policy and procedure development and ethics committees concerned with issues surrounding death, dying, and as a clinical instructor. So a wealth of experience, and we're so glad that Denise is here today to talk to us about putting this all together, what resources and local support we have here, and what are some additional considerations we have for implementing this age-friendly health system. So with that, I will turn it over to you, Denise. Welcome.
I am really excited about the work that you're doing here. I looked at our work as age-friendly healthcare is first to transform the practice of healthcare from a reactive to a proactive system. As you said, I work as a clinical trainer for Nova Southeastern, and I see the potential of this movement that's transforming the manner in which we do healthcare in America. Our task as part of the South Florida Geriatric Workforce Program has been to take the evidence-based concepts of age-friendly healthcare and along with our community partners, because we cannot do this alone. You need your partners to come alongside you to join you in this process. We want to bring this to the outpatient setting all over South Florida landscape where it impacts the elder adult. And as I think of urban health, I think of Dr. Donald Berwick, who is a pediatrician who was the co-founder of the IHI, and you just look at just the amazing work that he did, and I feel that Urban Health Partnerships has a good future ahead of you. Slide 2. I have no disclosures or conflicting affiliations. Slide 3, please. So age-friendly healthcare is a concept pioneered by the John A. Hartford Foundation, the Institute for Healthcare Improvement, in partnerships with the American Hospital Association, the Catholic Health Association of the United States, Kaiser Permanente, Trinity, and Ascension. The age-friendly initiative is a paradigm shift for both patient and provider that is spreading throughout the country. So traditionally, the practice of medicine has been reactive, a disease-centered paternalistic model where sick patients come to healthcare providers to be treated. We're finding that that's an outdated model that's resulted in sicker patients and high mortality, but it doesn't have to remain that way. And that's what we're here to discuss this morning. Next slide, please. So we know the Geriatric Workforce Enhancement Program is a federal workforce enhancement grant funded through HRSA. And one of the major goals of the grant is the promotion of age-friendly healthcare. The support for age-friendly healthcare has been growing for several decades with the goal of changing our mindset surrounding the delivery of healthcare. The Geriatric Workforce Enhancement Program is the action arm of the age-friendly health system that works by developing a healthcare workforce that implements the measures that evidence has shown will improve well-being and wellness in those 65 and over, and allowing them to live their best lives until their days on earth are completed. So as the Institute of Medicine declared in 2001, in words that still ring true, I think, between the healthcare we have and the care we could have lies not just a gap, but a chasm. Healthcare does not yet reliably transfer best known science into action, and processes frequently fail despite the best intentions of a dedicated and highly skilled workforce. Our healthcare system, which is established to heal, too often does just the opposite, leading to unintended harm and unnecessary suffering and deaths. The 100,000 Lives campaign was a nationwide initiative launched by the Institute for Healthcare Improvement in December of 2004, with the outrageous goal of significantly reducing morbidity and mortality in American hospitals by 100,000 lives. They began with 6 key interventions and a timeline, and the effort was wildly successful. At the end of the 18 months campaign, there were over 122,000 fewer needless deaths, which then led to the 5 Million Lives campaign. But trust me, even at the beginning, it was not without its loud detractors. Slide 5, please. So our learning objectives are to touch on the mindset undergirding age-friendly healthcare. We're undergoing a transformational shift in the way that healthcare is done. I want to begin with the Plan, Do, Study, Act. We are going to look at the overview of the 4 M's, the challenges and opportunities, and then we're going to look at the next steps. How do we achieve age-friendly certification? Next slide, please. So as the movers and shakers of the current generation enter into retirement, which are their golden years, they become increasingly vulnerable to the vicissitudes of age. Keeping in mind that patients are self-determining individuals assists us to care for them in a manner that respects and honors them. So I want you to always keep in mind that patients are the experts in what they want from healthcare, and we, the clinicians, are the experts in how to get them there. Next slide, please. So this is just a quick overview of the age-friendly healthcare. You've seen this slide, but it captures the 4 pillars of age-friendly healthcare. So for the purposes of implementation of the 4 M's, it's vital to first assess the 4 M's from the patient's perspective, then act to remediate factors that detract from the 4 areas that add value to your elder adult's life. So what matters? It's vital to elicit what gives meaning, purpose, and worth to our patients' lives, whether it's family, ability to care for self, self-purpose, making end-of-life decisions to avoid interventions that may not be desired. And after assessing what matters to your patients, act with your patient to make and meet goals that give their lives meaning and richness. Medications, assess the effect of medications. Do they help? Do they hinder your patients' lives? And helping them from doing what matters most. If not, then act. Review the medications, stop the medications that are unnecessary or which are hindering your patients from doing what matters to them. And mentation, assess your patient's ability to think clearly using tools to evaluate for depression, delirium, and dementia. Then again, it's vital to act, intervene early to address factors contributing to changes in mentation to prevent further decline. And recall that depression often predisposes to dementia. And mobility, assess your patient's gait, balance, and strength, and again, act as necessary in the way of patient education or referrals, helping your patient to set mobility goals to prevent isolation and injuries from progressive weakness and falls. Keep in mind that the 4 M's are not an overlay or an addition to usual geriatric care. Rather, they are synergistic, they reinforce one another. The 4 M's offer a new way of organizing care for the elder adult by ensuring that essentials are covered consistently in every setting that care is delivered, consistency leading to continuity of care with best outcomes. Next slide, please. So you've probably seen this slide also. It's the model for healthcare improvement, the Plan, Do, Study, Act cycle. It's a quality improvement tool used to test changes in real-life work situations. The PDSA cycle guides the test of change to determine if the change we make is an improvement. So it begins with taking a step back from the daily grind to become a systems thinker. So consider this. Every system is designed to get the results that it gets. Is our healthcare system getting results that serve the patient or getting results that serve the system? If we desire to sustain and improve the lives of our patients, the result has to improve patient outcomes while remaining sustainable. The Plan, Do, Study, Act cycle begins with a very proactive mindset. So consider how you might improve patient care. So you plan by taking an overview look, and then you decide on measures to be improved. You set a timeline. You start with just a few doable measures from the 4 M's. So you could begin with very low-hanging fruit. Example, advanced care planning. That's a struggle. People don't like to talk about it. Patients are suspicious. Advanced care planning needs to be talked about. Medication reconciliation, depression screening, just a PQH2, it takes a minute. Mobility assessment. Ask them, have you had any recent falls? Then do, once you have decided, implement the intervention or measure and decide how will it get done? Who will do it, and how are you going to measure it in the electronic medical record? It's important to document in a location in the record that can be easily counted. like a checkbox versus free text. Free text is not easily counted for credit. Again, it's important to set a timeline with a measurable goal. Example, you might say 3% of all the patients seen in the clinic will achieve one of each of the 4 measures within a 3-month span. And then study. At 3 months, have your IT department run the biometrics and were the goals or outcomes met. They're going to give you feedback. We can count this, but we can't count that. And that will help you to tweak a little bit. How are you documenting? Because you can be doing great work. If you're not documenting in a way that can be captured, you're not going to be able to get credit for it. And then you act. You act to adapt, adopt, or discard the processes that you're using to meet the goals. And then the plan, do, study, act cycle loops again and again, until the system achieves all of the desired outcomes. Next slide, please. So there are challenges and opportunities. Challenge is difficult. It's tough to change the system to be proactive. But if we want to change outcomes, we have to balance between being reactive with being proactive. So for those of us who remember the 100,000 Lives campaign, how many of you remember how difficult it was, and it still is, to get people to simply wash their hands? We would stand there, we would count, we would watch. People hated to wash their hands before and after. It was a struggle. Since March of 1855, during the Crimean War, 40,000 soldiers in British hospitals in Turkey were dying from the spread of infectious diseases like cholera, typhoid, typhus, and dysentery. Surgery was even performed without basic hand washing. So along comes Florence Nightingale and her 40 volunteer nurses, possibly prostitutes, because they were usually the ones enlisted as nurses in 1800 America, 1800 England. So Florence Nightingale instituted basic cleanliness and hand washing with the result of drastically decreasing morbidity and mortality. But we're still struggling to get people to wash their hands before touching and after touching patients. So we can agree that change is hard. We find that there's less family and community support, especially right now. We have a lot of people, as you said, they're moving into Florida, their families are far away. The other thing is the pandemic has been extremely isolating. So people are coming in, they're by themselves. It's a very isolating time, and it's difficult to get family and community support in a time like this, especially in Florida. Reimbursement has traditionally been based on alleviating symptoms rather than seeking root cause of disease, and that's something that we're working on. And due to limited reimbursement, visit times are short. 15 minutes, 20 minutes, we're trying to cover a lot of ground, and patients are sicker and they're older. But there are opportunities. So evidence supports the benefits of an age-friendly health system. And I think that, you know, at CMS levels, we're starting to get some attention. Reimbursements for well visits are increasingly incentivized. So if you go through your medical record, if you work with your coding department, you'll find that a lot of these really great measures have incentives built into the EMRs. There's codes that you can access to optimize your visits and to just make this really a financially sustainable process. So the age-friendly community partners are growing. They're implementing measures together. The groundswell is amazing. Patients and family are empowered as we educate them to participate in their own wellness journey. We can't do it alone. I tell my patients all the time, help me to help you. I can tell you what I think would help you, but you're the one who has to make these changes. So education of the family and the patient, I feel, is a super vital part of this process. And then finally, you know, change is happening. The ship is turning. Your system can be for part of the transformational shift that's happening in healthcare today. Slide 10. Beginning the journey, level 1 certification, recognition as an age-friendly health system participant. Completing the survey is the first step towards recognition as an age-friendly health system participant. The survey questionnaire will ask for a description of a plan of how the 4 M's will be instituted in your settings of care. So you see a link there. That is the link. If you click that link, it's going to take you straight to how do you get level 1 certification. When you get to that page, The institution will be asked to submit a description of how it's working towards putting the 4 M's into practice. And it is going to give you a guide there. That link, Age-Friendly Health Systems Guide to Using the 4 M's, that will be extremely helpful for you as you go through that and you decide what kind of changes that you want to make. And then the Institute for Health Improvement will review and provide feedback within 3 weeks of submission of your application. Next slide, please. So at level 2, you have an age-friendly health system committed to healthcare excellence certification. It's a recognition for being an exemplar in the movement based on the 4 M's work that is aligned with the guide, and at least 3 months count of older adults who were reached with evidence-based 4 M's care. To be recognized at this level, review the feedback you receive from the age-friendly health system at ihi.org when you submitted your 4 M's description survey. And then the feedback will indicate whether the description is approved and aligned with the guide. Once you've submitted 3 months of counts, the Institute for Healthcare Improvement will send you a committed to care excellence badge and a communications kit so you can celebrate this level of recognition in your local community. And slide 12. So here's the resources and references. There are a plethora of resources on how to do age-friendly healthcare well. The difficulty is the implementation. It is super important, as Tanya was saying, to get buy-in from those who are able to make change in your institution. We can have a great idea, but it needs to be brought to those people who can really make the change to make this an easier process to get through. So then the next slide, please. In conclusion, to quote the co-founder of the Institute for Healthcare Improvement, Donald M. Berkwick was a pediatrician who stood back and said, we can do this better. And he did. The names of the patients whose lives we save can never be known. Our contribution will be what did not happen to them. And though they are unknown, we will know that mothers and fathers are at graduations and weddings, and that grandchildren were no grandparents, and that they might never have known, and holidays will be taken and work completed and books read and symphonies heard and gardens tended that without our work would never have been done. So next slide, please. You can contact me at dk644@nova.edu, and you will recognize B.B. King, the king of the blues. And if you don't, I encourage you to look him up. He was singing and playing the blues to adoring fans until 6 months before he died at 89 years old. And that's the way to finish up a life well lived. The thrill does not have to be gone. I encourage you to join us in keeping your patients' lives full of thrills to the very end of their time. And that's all I have.
Thank you so much, Denise. I love those words that you shared at the end. It's really why we're here and why we should be doing this work. So thank you. We're going to leave the questions. We have one more presentation. You have some really nice notes there too. I'm going to introduce to you our last speaker. Dr. Nish Pandya is a professor and chair of the Geriatrics Department at NSU, Kiran C. Patel College of Osteopathic Medicine, and the project director of the HRSA-funded Geriatric Workforce Enhancement Program. She is a certified medical director and a geriatrics fellowship program director with an active clinical practice in which she teaches health profession students, residents, and fellows. Dr. Pandya is a past president of AMDA, the National Society for Post-Acute and Long-Term Care Medicine, and a past chair of the Interdisciplinary Clinical Practice Committee. She has participated in the development of multiple clinical guidelines and position statements and is recognized for her work in the area of diabetes in the elderly. She is board certified in internal medicine, geriatrics, and endocrinology and metabolism, and she holds the distinction of being a Fulbright Senior Specialist Scholar. And I'm so happy to welcome Dr. Pandya back to our series, and she's going to help give us an overview of resources and next steps.
Thank you so much, Isabel. Can everybody hear me?
Yes, I hear you.
Okay, so I just want to summarize what we've learned so far, or my take on it, that as everybody has expressed, the demographic and social imperative for changing the way we take care of older adults is here. We really need to think about it every day with every patient. And I think with the 4M framework, we can adopt a more holistic approach that actually meets the needs of older adults and leads to greater satisfaction in their care in all settings. We've heard a lot about the hospital setting. We at NSU have a series of outpatient clinics, so we're trying to focus our efforts there. Next slide. So what Isabel said in the beginning was very important. Next slide, I think. We need to, healthy aging is an investment, not a cost. And I think many of you have expressed that. And we need to recognize, as Denise so eloquently said, that, sorry, we're moving too fast.
Sorry about that.
Okay, no problem. So elders can be a vital force, not only to the economy, to the workforce, to the community, and enrich their own surroundings and their families. And we all think of what a loss it is when we lost our parents, if we have done so, and especially our grandparents. So we need to also look at the way we think of our older adults and our patients. And we need to also examine our own biases, and we do have biases. I strongly feel that we should be an advocate in whatever field, whatever bubble, whatever pond we live in. We should be strong advocates. Our influence is greater than we realize. And every person you touch, every medical assistant, every patient, every nurse, and you model this sort of behavior, you educate, you support them, that will also help our movement move forward. Next slide. So one of the presenters said, one of the 5th M's could be multi-complexity, because all of us have realized it's not easy taking care of older adults, especially in your 15 to 20 minutes when they have, 8 or 9 diagnoses and maybe 15 medications. I mean, we've often all worked through lunch hours trying to sort out the problems that our patients face and trying to coordinate their care. But the benefits are tangible. We could reduce avoidable emergency room visits. Apologies. Avoidable emergency room visits. We could reduce polypharmacy and adverse drug events, which affect a serious, a significant number of people and are responsible not only for ED admissions, but deaths. Early detection of the 3Ds, dementia, delirium, and depression. And we could reduce fall-related injuries. So there are some definite tangible benefits. And of course, as everybody has said, in your own setting, pick what your problem is. And Dr. O'Neill in the first module gave us a really good selection of assessment tools to screen for these problems. Next slide. I really loved the presentation from Anne Arundel Medical Center on what matters. And the important thing they said was that that's included in their EHR and it drops into their care plan. So it's always there to inform the next visit, the next admission, the next clinician who's looking at the chart. And I took to heart what she said, stories matter, pets matter a lot. And M&Ms and food is a great way of educating. I really want to try the M&Ms for the 4 M's in our setting. And so Denise, let's brainstorm on that. But I think that can lead to some change. She stressed the importance of buy-in from leadership and on-the-ground clinicians and teams, collaboration, and also using publicity to acquaint the larger community with their cause. And although it's not easy for every setting to have an acute care unit for elders, but we can work in a similar model. And those areas could be the focus of learning and inform us how to improve care. for patients. So we don't all have to have ACE units, but certainly practicing care of elderly in this vein, in a team-based effort, using the 4Ms as our framework could really improve the inpatient care of elders. Next slide. And again, their passion and clinical champions were what seemed to drive their efforts so much. And they chose measurables that matter in their setting and that matter to many of us, readmission rates. They chose the ease of departure, which I found interesting. I assume that's how feasible was the discharge, how prepared was the patient, were the services post-discharge available, and length of stay. So these are all still very crucial measures of healthcare delivery and outcomes that we're all, held to task. Next slide. And the important thing, Dr. O'Neill, Mary Tinetti, famous geriatricians, and other people have said with what matters is if you don't know where to start, why not start where the patient wants? And again, as Denise and others have said, this is so important. Maybe we should just be guided by the patient. Next slide. And mobility is medicine. So that was also part of the mobility presentation. And I love this, the way it was coined. And patients and clinicians should realize that mobility and function during the hospital stay can determine whether you get to go back home, whether you end up in a nursing home or acute rehab setting, or whether you never get to go back home. Okay, so this is so crucial. And sitting or laying in bed is almost the rule in the hospital. I remember when I was an intern too many years ago to talk about now, but we were so scared. And the first order we would write in the patient's chart would be bed rest, because we thought that sounded good and they were in the hospital, right? But times have changed. Bed rest is not necessarily a good thing. And looking at fall risk, we need to look at every patient in a unique way. They all have different risks, and ask about falls at all visits and all medical encounters. I think those of you are fortunate to have mobility volunteers, way ahead of the game. And the presentation also talked about mobility is medicine as an education card given to patients, and a mobility plan that was advancing day by day as the patient, negotiated their hospital stay. I think that's a great way to empower patients. Next slide. And Dr. Ombi talked about dementia prevention and brain health, and we know few drugs are available to treat cognitive impairment or modify the course of Alzheimer's disease, and the latest release of aducanumab may or may not be what we're waiting for. We don't know. But the important thing was half the cases of dementia could be delayed or prevented. So this is everybody from middle age onwards, or even in younger years, can adopt lifestyles, control their blood pressure, their blood glucose, their weight, their activity in order to prevent dementia. Exercise has definitely a positive impact, and if you can do nothing else, walk. And Mediterranean diet has been shown to be reduced with decreased risk, and also sleep quality. So ask about sleep. Next slide. And he also talked about advanced cognitive training, and an increased speed of processing is associated with lower risk of dementia, but combining physical and cognitive training could be even more effective. So the key recommendations were cognitive and strength training 3 times a week, daily aerobic exercise, mentally stimulating activities, meditation, Mediterranean diet, and attention to sleep. Next slide. And finally, the focus on medications. Medications are like clothes in our closet. Get rid of what you don't want, what you're not using, give it to, donate it. Obviously, we're not going to donate medications, but essential medications are necessary. They should be used appropriately for the time that they're useful. Be wary of anticholinergic medications that could lead to urinary retention, confusion, falls, and many examples were given. And beware of a medication cascade where one medication is used to treat the side effect of another medication without realizing that it's the first medication that's the problem and one should remove it. So that's the cascade. And I always tell my learners, whenever there's a clinical problem, first look at the medication list. Always keep looking at the medication list. And also try to encourage patients to bring all medications to the office and the emergency department. I know we're often horrified when they do actually do that, but it's worth going through that list. Next slide. So we were told about the Beers criteria, very useful tool, and we circulated to all our trainees. The STOP criteria, where you screen everything for potentially inappropriate medications. And the big offenders still remain benzodiazepines, opioids, sedatives, sleeping pills, muscle relaxants, which we often think are so innocuous, tricyclic antidepressants, antipsychotics, and anything that has anticholinergic activity. Not to say you never use those. There's a role for some of these medications, but beware of the interactions. Use them for a limited amount of time and deprescribe whenever possible. Next slide. So I just wanted to show you our website, which is under SFGWEP. You'll find that very easily. And on the left, you'll see our faculty, subject matter experts, and also our education tools. Next slide. And some of the resources we're offering are a series of webinars around the 4M framework. We have Geriatrics Journal Club 3 times a month, which is presented on Zoom. We have a series of web-based geriatric trainings, which are also available. And we've just started a series of podcasts, the first one, which has been released, and we'll be happy to circulate it and have as many listeners as possible. And with our COVID supplemental grant, we developed a series of COVID-19 resources for community members and for telehealth. So thank you so much, Isabel. My email is on the next slide, I believe. And I really appreciate you arranging this series of modules. It's been very, very informative.
Thank you so much, Pandya. We really enjoyed putting this together and working with all of the speakers. I actually see a couple of the speakers here from the past modules, which is really great to see. Thank you for being here. And we are out of time, unfortunately. We don't have time for questions. I did want to just do one question, and I wanted to ask Tanya, how do you overcome resistance from clinicians about time constraints? So what are some of the things that you've done to be able to overcome resistance from implementation?
So what we have found is most helpful is to continue ongoing education. And we have created, we're not perfect by any stretch of the imagination, but we're very resource rich in our facility. So we have mobility techs that can help with the ambulation. We have almost every unit has a pharmacist available to help review medications. We have a strong supportive care department, palliative care resource. And we really try to look at the patient as a whole. It is challenging, always challenging, because there are so many forces that are coming at us from so many angles. But just trying to remember that the patient should be our focus, and we should be aiming to get them where they want to be when it's time for them to be discharged.
Thank you. That's wonderful. Really inspiring to hear all the work that's happening around our country. We got to hear from speakers from really around the country. So thank you to everybody that's participated. I want to ask you to please help us by completing an evaluation and knowledge survey. The link is in the chat on the right. And if you can't use the chat, you can also hold your phone up with the photo app open, and that QR code will actually take you to the survey as well. This really will help us in evaluating this training and series and in feedback. And thank you again to everyone that has participated in all these modules. We have recorded all of them and we'll be sending out links to them in case you missed one or two, or you want to share them with your colleagues. These will all be available to you after this series. And again, I want to thank everyone, our speakers today especially, and we look forward to seeing what comes next here in South Florida with the age-friendly health systems. Thank you so much, everyone.